Welcome to Future Conversations, the podcast that explores research through the lens of tomorrow by Monash University, Malaysia.
Welcome to Future Conversations, a podcast by Monash University, Malaysia. I am Professor Mira Sivasodi from Monash University, Malaysia, and I have the honor of having with me Professor Sir Michael Marmot, Professor of Epidemiology and Public Health at University College London. He's also Director of the UCL Institute of Health Equity. Professor, you're also author of many books, one of which I'm just going to mention, which is titled The Health Gap, because that's the book you seem to be referring a lot to many of your talks and, panels that you actually sit on. Now, the Marmot Review in 2010 remains a cornerstone in the discourse of health equity. Now, Professor Sir Michael Marmot was an early proponent of shifting from the traditional model that focused on how health affects economic status to a new view that economic status affects health. In short, the evidence shows social disadvantage leads to ill health. To people in the medical field, Sir Michael, you're a legend. The Marmot Review is part of the curriculum in medical schools. You also have the ear of some governments who acknowledge the work that you do and have adopted it in some cities in different countries. But to those of us who are listening to you or watching you right now, in the area of social determinants of health in cities that they don't quite understand, who is Professor Sir Michael Marmot?
I could artificially divide my working life into two. In fact, it doesn't feel like that. But the two would be, the first part was really a full-time researcher trying to understand how social conditions impact on health. So I spent my research life doing that.
Yeah, and what drove you to do this?
I've written about this, and I wrote about it in The Health Gap. As a young doctor, and even as a medical student. As a medical student, I used to think disease is failed prevention. I thought, cancer. Why would you want to do surgery for cancer? Wouldn't you want to prevent it? It seems so crude, you try and cut it out. I mean, it's systemic. There'd be cancer cells everywhere. Yeah. Trauma. Well, have safer roads, people wouldn't have car crashes. Heart disease, surely we should prevent it. So I was already just in my head, not as a scholar, thinking that disease was failed prevention. And then as a young doctor, when we would see the same patients come back again and again, we'd patch them up. People with chronic obstructive pulmonary disease or asthma, people in cardiac failure, we'd patch them up, send them home, and there they were again.
But why do you think we've come to this? If we can prevent something, why is there no will to prevent?
I think there is a will to prevent. The question is, why don't we apply it? So you asked me why am I doing what I'm doing? Yeah. And when you talk to people about inequalities in health, the fact that poorer people have worse health than people who are less poor, different ethnic groups, the immediate reaction is, it must be access to health care. Well, access to healthcare is vitally important. We need universal access to high-quality care. And the conversation usually stops there. That's all people talk about. Yeah. And for understandable reasons. The ministries of health, most of their concern is with hospitals and providing healthcare facilities. If you can get beyond that, people then say, it's behaviours, where that poor people smoke too much and they eat unhealthily, they don't run round the block, and that's why, or they don't boil the water, they don't look after themselves properly. That's why they get sick. My starting position is if you see differences in health and disease among groups of people where the groups are based on defining individual characteristics, gender, socioeconomic status, ethnicity, my starting position is that those differences in disease that we see are not due to the individual characteristics of the people that make up those groups. It's due to the operation of society. If society treats women differently to men, if it treats people with disabilities differently from the way it treats people without disabilities, poor people differently from non-poor, different ethnic groups differently. We've got to look at the operation of society. And that's what I was doing in research for a big part of my life. And I said artificially I could divide it into two. And the second part is trying to apply research findings to change things, to improve, to act. And I say it's an artificial division into two because in one sense I'm still the research scientist. I'm still looking at the evidence. What does it tell us? What have we learned? How can we apply our latest understanding? But very much my orientation now is to affect policy and practice.
Yeah. Which is, I wish more researchers had that sort of mindset to want to work towards application and, create change, which is fantastic, which is what you've done. I'm just going to roll back a little to the social determinants of health for those of us who've been in the medical line and who understand health. It's huge. Sir Michael, I mean, when I was given the opportunity to interview you, I thought to myself, wow, this man is a legend. I mean, you've brought about something called the Marmot Review, which is coming out of the WHO's social determinants of health in 2010. And that's when the Marmot Review actually came out. And you spoke about 6 areas in which we needed to look at. Would you like to go through that with us?
Sure. Let me just go back a step, though, before then, which is that to when this started, as I said, I was doing research on how the operations of society impacted on health and disease. And I had colleagues who were doing something similar. And somebody from the European office of the World Health Organization said, could you package that knowledge in some way, put it together in an accessible way? I said, sure, and we did it. We called it The Solid Facts. But we also produced a book with the evidence published by Oxford University Press, and I called it Social Determinants of Health. I'm not sure where I got the title from.
I was about to ask you.
I've Googled it, and whenever I Google, it comes back to me.
Right.
So I don't actually know. I don't lay claim to originality. I'm not saying I did it. I just can't find where I got it from.
So okay. It's yours now.
So I guess it's mine.
Yes.
So we had this book with our best understanding of the evidence. Then I went to the World Health Organization and said, you need to set up a commission on social determinants of health. And the Director General then, J.W. Lee, said yes. And I chaired that commission, and we produced our report, Closing the Gap in a Generation. And it was in the wake of that report that the British government, was then Prime Minister Gordon Brown, invited me to conduct the Marmot Review to say how we could apply the findings and recommendations of that global report to one country, England. We convened another group of experts, we deliberated, and we distilled it down to our 6 domains of recommendations. Give every child the best start in life. Number 2, education and lifelong learning. Number 3, employment and working conditions. Number 4, everybody should have at least the minimum income necessary for a healthy life. Number 5, healthy and sustainable places in which to live and work, including housing, neighbourhoods, environment. And number 6, taking a social determinants approach to prevention. So you don't just say, don't smoke, drink in moderation, eat healthily. You recognize the constraints on people's behaviors and you try and address those constraints. Those were the 6 Marmot principles.
So a little bit of behavioral science is what you're referring to.
Quite a lot of understanding of how society operates to influences people's behavior.
Absolutely, yeah. Which is something I think there's a huge gap between bringing about awareness and then creating or translating that to change in behavior, which is, I think we're grappling with it even here in Malaysia. You've added 2 more domains to the Marmot review. This is post-pandemic, I understand?
Well, the 7th one, I'd been interested in ethnic differences in disease. I wrote a monograph in the UK, which we published in 1984, of mortality by country of birth, looking at immigrants to the UK. So I've been interested, but we don't have very good data systematically. Race, ethnicity is not routinely recorded. We don't have good data. But in the pandemic, it was recorded, and we saw this staggeringly high mortality among men and women of African origin, Afro-Caribbean, Pakistani, Bangladeshi, to a lesser extent Indian, mortality from COVID-19. And that alerted, we've got to keep looking at this. And so number 7 was tackle racism, discrimination, and their outcomes. And number 8 was kind of there all the way along, which is tackle health equity and sustainability, environmental sustainability together. And that's terribly important, because when I started talking to sustainability folks, people concerned with the climate crisis, they hadn't thought about health equity. That just wasn't on their radar. And people who are concerned with health equity may or may not have been concerned with the climate crisis. But they're vitally important, because you need to make sure that the steps you take to deal with the climate crisis aren't making health equity worse. If you have congestion charging, if you make it steep enough to change behavior so people don't drive their cars into the city, then if it's steep enough, you'll only have the Mercedes and BMWs driving around, and ordinary people won't drive around, so they'll be disadvantaged unless you replace it with public transport and making other forms of transport safe. So having an equity focus, a health equity focus when you're thinking about the climate crisis is terribly important.
Which brings me to integration. There's a disconnect in most governments and with most agencies. Everyone works in silos. How do we bring about better integration within governments to create this change that you're talking about?
I wish I knew the answer to that question. What we've found, what we've been doing in Britain, is working with local areas. And we've been doing that for 2 reasons. The negative reason is after I produced the Marmot Review in 2010, commissioned by Gordon Brown's government, the government changed. That's what happens in a democracy. You have elections, and one party wins, another party loses. Well, in fact, there were 2 parties joined a Conservative-led coalition government, and they went in the opposite direction. Didn't fit with their philosophy. So I said, give every child the best start in life. They took steps to increase child poverty. They closed 1,000 Sure Start children's centres. So they stopped spending, they reduced the spending on education, and so on. Their philosophy drove them in a different direction. So the negative reason for working with cities and localities is the national government wasn't doing it.
Yeah.
The positive reason, and it comes back to your question about cross-government action, is much easier to get cross-government action. Before I went to Hong Kong and Malaysia, the week before, I went to Liverpool, which is, I hope, going to be one of our Marmot cities in 2025. And I met with the corporate leadership of the city council, the chief executive, and then sitting around the same table, all on first-name terms. The person responsible for children's services, for adult social care, for housing, for transport, all the key people for education, all sitting around the table together. Now, normal life, they don't always necessarily cooperate the way one would like, but nevertheless, there they are in the city council offices, all round the same table, talking to each other. I then went to meet the public health people. I spent a whole day in Liverpool. And in the afternoon, I met various voluntary and community sector groups, civil society groups, actually supported by one of the football clubs, which is interesting. So we've got city council, we've got public health, and we've got the voluntary and community sector.
Yeah.
And they talk to each other and they communicate.
How wonderful is that?
Well, it's easier to do at the local level than it is at the national level.
Okay.
Because people sit in their big ministries and it's more difficult. Not impossible, but it's more difficult.
You met Malaysia's Minister of Health yesterday. How did that go? And the reason I ask you is because Malaysia has seen 4 ministers of health in the last 5 years. And Dr. Zul was our minister some years ago, and he's come back as minister now. I'm very fond of him. How did that discussion go?
The real answer, I mean, the discussion went well. We had a very nice meeting. The real answer will be, let's see what happens next.
But somehow, I mean, if we're working with you, who knows? We could be a Marmot nation, or even just Kuala Lumpur or the Greater Klang Valley.
Well, that's what I'd hope,
yes.
Because we have a set of principles that will create fairer societies where everyone has an enhanced possibility of having a flourishing life.
Yeah.
So that's what I'm putting forward as a proposition. And the minister was certainly interested. I said, you see, I'm being guarded about the conversation.
Yes, you are.
I have lots of conversations with good people. Let's see what happens next.
Well, you have the ear of many governments in the world, not just in the UK. So I'm quite positive that there will be good outcomes from your conversation with him. The Marmot review was looked at again in 2020, which is 10 years later. What did you find happened over the decade?
What we found was alarming. If you look at what had been happening to life expectancy in England, so we did it for England, but the figures for Wales, Scotland and Northern Ireland, the other constituents of the United Kingdom, are very similar. If you look at what had been happening to life expectancy in England, it had been improving about 1 year every 4 years, taking back to the end of World War I, for 100 years. And in 2010, there was a break in the curve. The rate of increase slowed dramatically and just about ground to a halt. The regional and socioeconomic inequalities in life expectancy increased, and life expectancy for the poorest people got worse. So you think, wait a minute, this hasn't happened before. This is a significant change. And the proposition that possibly something government had done might have been responsible for this. You can see why the government was a bit sensitive about this. And one argument, they said, well, maybe we just reached peak life expectancy, had to stop improving sometime. Nope, that was not the explanation. We looked at all the other rich countries. The rate of improvement had slowed more markedly in the UK than in any other rich country except Iceland and the United States. Nope, we had not reached peak life expectancy. Other countries that had longer life expectancy than us were still going up, and we had levelled off. We then looked at the Marmot 6, at my 6 domains of recommendations, and mostly they'd gone in the wrong direction. I mentioned earlier in our conversation, child poverty had gone up. Children's centres that supported families had closed because of lack of funding. The central government funding to local government went down by 59% over the decade. What? 59%. The main source of funds for local government is central government, and they reduced it by 59%. Now, they did allow local government to raise more money. That meant that the net reduction was only about 34%. How do you function as a local government if your budget's been cut by more than a third?
Yeah.
And the more deprived the area, the steeper the cuts, which predictably would make health inequalities worse, predictably would damage health in the poorest areas. And that's exactly what we saw. When I pointed this out, they said, no, we reject that completely. Look at the evidence. No, we reject that. Why do you reject it? Because we don't like it. Not because it's wrong, we just reject it.
Are you for cash handouts? Because there's a debate in this country. We have allocated a fair amount of cash handouts from the pandemic, and that continues. How do you think, how effective are cash handouts that could possibly help towards better health for the socioeconomically challenged?
Well, if you're a poor family and you don't have any money, a bit of money is quite helpful.
Yeah.
My fourth recommendation was everyone should have at least the minimum income for a healthy life. But you notice that was one of 6, now one of 8. That's not the only thing that needs to be done. If people can't afford to feed their children, then something has to be done. And that might mean money. It might mean the price of food. It might mean other things. But that's one of 4, one of 6, now 8. And that's not all that needs to be done. And coming back to the United Kingdom, we looked at the figures, that the decisions that the Minister of Finance took on taxes and benefits for families with children increased the inequalities. So if you were a family with children in the bottom 10% of income, your income would have gone down by 20% as a result of the changes that the Minister of Finance made to taxes and benefits over the 10 years. So you ask me, will cash help? Making poor people poorer won't help.
Yeah.
And that's what the government did. It made poor people poorer.
Right. And, let's talk about the digital divide. That's area of big concern. And we saw that during the pandemic as well, right? We had no choice but to look at digital and that there was a huge divide at that time. Professor, did you take into account some of that, or what have been your observations when it comes to digital divide and how that plays into equity and access?
It's a very important question, and we have perhaps not paid enough attention to that. We saw it during the pandemic, particularly with education, that children from more advantaged backgrounds, their schools were better organised, so they could do online lessons when the schools closed, and the children had access to computers and laptops and iPads and the like, so they could do the online lessons. Poorer kids didn't have the same access, and it's much harder if you're living in more crowded accommodation to do online lessons, do homework and the like. So we saw it particularly with an increase in the educational divide as a result of the closure of schools during the pandemic.
And, that is what you speak about, social determinants of health. Nobody sees the direct link, but it does affect in many ways. Let's talk about budgets. Malaysia spends under 5% of public healthcare expenditure. I think it's about 2.9%. Even with the private sector expenditure, it's less than 5%, slightly less than 5%. That's a very small amount of money being spent on health. Is it all about the budgets, really, to maintain good health or good access and equity when it comes to health?
Well, let's get clear. When you talk about spending on health, you don't mean that. You mean spending on health care.
Yeah.
So the amount that you spend on health care is not the major determinant of the health of the population. It's very important, as I've always said. Universal access to high-quality health care is important. But we know the major determinant of the health of populations is not the percent of the budget spent on health care. And there's real confusion about this because it's not just you, but the OECD, the International Monetary Fund, the World Bank and so on, they talk about spending on health when they mean spending on health care. And then I've had, economists, PhDs saying, we're going to look at spending on health and how that, impacts people's health. No, you don't mean that. You mean spending on health care. So, yeah, you probably do need to spend more than 5% of the budget on health care. But that's not going to be the major determinant of the health of the population. How much you spend on education, on social protection, on improving the environment, on housing, all of those things are going to be key to the health of the population.
Governments and good governance. Talk to me about that. And what have been your observations in the UK?
I always look at the numbers. Let me give you a statistic. If you look at the excess mortality during the first wave of the COVID-19 pandemic among rich countries, so excess mortality above what you would have expected, and then look at the change in healthy life expectancy in the decade before the pandemic, what we see is the greater the improvement in healthy life expectancy in the decade before the pandemic, the lower the excess mortality during the pandemic. So countries like the United States and the United Kingdom that had poor records in healthy life expectancy pre-pandemic, in the first wave, 2 waves of the pandemic, had large excess mortality. And then one asks why. And I asked why. And I put this in my Build Back Fairer report, which I did after the 2020 report on the first year of the pandemic. And I asked why. What's the link between poor health in the decade before the pandemic and poor management of the pandemic? And I thought the link was fourfold. First, the quality of governance and political culture. Second, the rise in social and economic inequalities. Third, the disinvestment in public services. And fourth, we were not very healthy coming into the pandemic. So come back to the first, which was your question. What do I mean by poor governance and political culture? In the United Kingdom, between 2016 and 2022, II, we had 5 prime ministers, 7 ministers of finance, 7 secretaries of state for health, 10 housing ministers, utter chaos between the Brexit referendum and 22 in 7 years, 6-7 years. Utter chaos. Nobody was governing. They were just fighting for positions, squabbling like rats in a sack. They were worrying about how to do Brexit and lying about what they were going to do with Brexit and God knows what. It was utter chaos. Whatever good governance looks like, it doesn't look like that.
And, the Marmot review has been implemented in a place like Coventry, for an example. What do you think has worked in Coventry? Have there been outcomes? And you speak a lot about monitoring. The Marmot review emphasizes monitoring. How should Malaysia... we can take a leaf out of this example for, if you may. If it's not Coventry, if it's even somewhere else in the UK which you think would be a good example, share that with us.
Well, the first thing is, if you go to Coventry and meet people from city government, from the voluntary and community sector, from the health sector, from the universities, you would detect a palpable feeling of excitement. They're energized. They feel they're doing something good. They're on a team trying to work together to create better lives for the people of Coventry. So that's what they're doing. So that's the number one ingredient, a commitment to improving the lives for everybody in Coventry. Then the question is, how do you do that? Well, I'd say there are 3 components. The first is engaging people. Don't invite Marmot in to tell everybody what to do. Don't do that. Engage people. What are their priorities? What concerns them? What's their lived experience? How do you understand the reality of people's lives? Second, charismatic leadership. And we had that in Coventry. The chief executive of the city council, not the elected members, but the chief executive, the employed person, the elected members too. They were very enthusiastic, still are. But charismatic leadership, saying, we're doing this, this is true. And this is all done within a framework of budgetary constraint. There wasn't a lot of money. As I said earlier in our conversation, there were brutal cuts to local government budgets. Brutal. So it's not as if they were saying, look, join us, there's lots of money, you can get money for all your services. They weren't saying that at all. So charismatic leadership. And the third is all the different sectors were all engaged. The health and care, the police, education, fire and rescue, the voluntary and community sector, business. All the different groups were involved, working together. Really wonderful. In Greater Manchester, or the City of Manchester, which is one of the 10 local authorities in Greater Manchester, they've got a Marmot working group. Well, they've got one in Coventry too, where they all get together on this Marmot group and work out what they're going to do and how they're going to do it. In Coventry, it's supported by a Marmot monitoring tool, which you can look it up on the web. They've got something similar in Greater Manchester and in the City of Manchester and in the other places in which we work. And these places started coming to us. So Coventry did it on their own bat. And they said to me, do you mind if we call ourselves a Marmot City? No, I'm fine. And after 5 years, they said, we're so pleased with this. We want to keep it going. Is that okay with you? I said, yep, that's fine with me. And the others, by early next year, we will have 50 Marmot places in England, Wales, Scotland. Northern Ireland, are you listening?
Malaysia's listening too. So the evidence is clear. The more local you get people involved on a local level, I apologize, the better it is to execute. And I think that leads...
No, I wouldn't quite say that. The evidence is clear that that's a good way to function, but we need national government to come in behind us. It's not enough to say, well, the national government is increasing child poverty and we'll try and combat that locally. No, we'd like the national government to reduce child poverty. We'd like them to fund local government properly. So no, it's not saying the evidence is clear, you've got to act locally. You do have to act locally, but you need national government as well.
You know, I was reading recently, and I have to ask you this question. The U.S. Health Department is now being led by Robert F. Kennedy Jr. How do you feel about that? How is that going to impact health globally?
I mean, the first thing to say is Robert F. Kennedy, his father, was an inspirational figure. He was an intellectual, so that may be a bad thing in many people's eyes. It's a good thing in my eyes. He was thoughtful. He made inspirational speeches. He, for example, a much quoted statement he made about the shortcomings of gross domestic product, when I won't do it justice, but it said it doesn't capture the play of our children, poetry, love of country, commitment to family. In short, it doesn't capture any of the things that gives our life richness and meaning. Yeah. Wow, that's inspirational to have a major politician, U.S. politician, talk that way. It's inspirational. He's no Robert F. Kennedy, the Jr. I know it's old-fashioned to rely on science and evidence. It's quaint. In a post-truth world, we dinosaurs, we people in universities. What's Monash University for? What's any university for? Monash University is for knowledge and understanding. It has a set of values. You don't value somebody who ignores the evidence the same as you value somebody who tries to make reasoned judgments based on the evidence. So somebody who says there is not a vaccine that works, what have we been doing in the universities if it's not trying to work out which vaccines work and which ones don't? The triple vaccine causes autism, MMR. Wakefield got struck off the General Medical Council for cheating. Not just was it a bad quality paper, it was obviously a bad quality paper when he published it, but then it turned out he cheated. He manipulated the data. So there's no evidence that the triple vaccine causes autism. The nominee to head the Health and Human Services Department in the US is still quoting Wakefield's discredited paper. Why are you quoting that? Why don't you look at the science? So it's really a bit upsetting to have somebody who's ignoring the science. What are we all doing? It's saying that what we're all doing, the Monash, close it down. Why would you teach anybody anything? Why would you have committed people with values of truth and knowledge and understanding trying to help young people further their lives with those values? Why would you do it? So this is running in the face of everything that a university like Monash stands for. How could we look at that with equanimity?
What keeps you out? What keeps you up at night, Sir Michael?
Jet lag. I go to a Minister of Health. Let's take a random example. In Malaysia. And I talk to him about the importance of cross-government action. And he knows that his major task is managing the healthcare system. He knows that. And then I think, how am I to convince him that somehow what education is doing, and how am I to convince the Minister of Education that she should be involved in this? How am I to convince the Minister of Finance that they're normally he, but we've got a female Minister of Finance in Britain now.
Yes, you do.
First time. How going to convince she that health equity, these things I'm talking about, are important? So that's what keeps me up at night. And then the second thing is, are we doing any good? Is any of this working? How are we going to find out? We need to know. And these are not pucker experiments. It's not as if you're in a lab and you're doing an experiment, you need to know, is it A, B, or C that caused X, Y, or Z to happen? That's how you do science. We're not in that league now. You've got Coventry and Manchester and Liverpool and Lancashire and Newcastle and Leeds and Waltham Forest, and they're all very different. And we're trying to figure out whether what they did made a difference. Very difficult.
Yeah. And
but that can't stop us. You asked what keeps me up at night. There you are.
every generation, you have mentioned in some of your talks that every generation we think will be better off in terms of health. You don't see it going that way. Why is that?
Well, firstly, it's not just that I don't see it going that way. Today's adults don't see it going that way. What's interesting in European countries and in the United States, if you ask adults, will your children have a better life than you? A minority say yes. In lower income countries, people are more likely to say yes. And they're probably right. You know, things are getting better in lower income countries. Look at Malaysia. Things got better. It would be reasonable for people to say, I think our children will have a better life. Certainly it was. And it was in Britain for my parents to say that. So now parents are not saying that. And let me give you some figures again. You see, I'm just wedded to the numbers, to the evidence, to the data. For people in the United States, for people born in the 1940s, there was something like an 80% chance that they would have higher income than their parents. For people born in the 1980s, so they're now in their 40s, it's 50-50. So it was 80% chance they'd have higher income than their parents. Now it's only 50% will have higher income than their parents. Half won't. Half won't have higher income than their parents. That's the American dream. If you want to know why people are voting in crazy ways in elections in the United States, half the population think it's getting worse. And our kids won't have the opportunities we had. That's not the American dream. The American dream is our kids will have it better than us. That's the universal dream, isn't it? Certainly not that our kids will be worse off than we're prepared to give, sacrifice, invest, all those things so our kids will have better lives. Now, to come back to your question, why? What's gone wrong? Well, what the evidence shows is two kinds of influences that determine whether children will have better prospects than their parents. One is the magnitude of inequalities. As inequalities grow, income inequalities, as the gap between the rungs of the ladder get bigger, it's more difficult for the next generation to go from one rung to the next. So the greater the inequalities, the less the social mobility. And the evidence is very clear on that. And as income inequality has been growing in many countries, particularly in the United States, so social mobility has declined. The second is how much we invest in our children. Now, I don't know the figures for Malaysia, but I do know the figures for the OECD countries, the rich country club. The average investment in children aged 0 to 5 is $6,000 per child per year. In Norway, they invest $12,000. In Sweden, 11, in France, $9,000. The average is 6,000. In the UK, we invest 4,000. The US, 3,000. So both of these, how much we're prepared to spend on our children in good early child development, good preschool, supporting families and the like, and the magnitude of inequality is affecting the mobility, the social mobility and the chances for the next generation. Now, if I look globally, what's happened is very welcome. Globally, there are exceptions. Child mortality, the international gaps have reduced. Child mortality has come down in low-income countries. It's improved. So the gap between the low-income and the high-income countries has got smaller, and that's very welcome. Child poverty has gone down globally. Now, that's much to do with China, because there's so many Chinese and they've reduced child poverty. So it's much to do with China. But globally, child poverty has gone down, about halved over a generation. So there's progress. It's just when we look within countries and we start drilling down into these data, we see these negative trends.
Would you say then, just focusing on the first domain of the Marmot review will bring about huge impact when it comes to equity?
Well, the thing about focusing on the first domain is you have to focus on some of the others in order to focus on the first domain. Give every child the best start in life. It means parents have to have enough money. So that's domain number 4. It means decent housing. That's domain number 5. It means good nutrition. That's domain number 6. It means good education. That's domain number 2. So just focusing on children, you've got to do the whole deal. Yes. You can't say, let's just do this one. That's why when people ask me, what's the one thing you would recommend? I'd say, implement my report. That's the one thing I'd recommend.
The Marmot. The Marmot cities, come on. We need to go with that. I mean, it's been a pleasure speaking with you, Sir Michael, reflecting on insights of the Marmot Review. What would you like to leave us with?
If I answered the question seriously, what's the one thing that you'd like to do? It's put equity of health and well-being at the heart of all policy making. What we're trying to do is create a fairer society where everyone can flourish. And if we do that, we'll have better health and greater health equity.
Professor Sir Michael Marmot, Professor of Epidemiology and Public Health at UCL, also Director of the UCL Institute of Health Equity, speaking to us on Future Conversations. I am Mira Sivasodi for Future Conversations, a podcast by Monash University, Malaysia.